Hi everyone, I am Briley Davis and together with me is June Cheryl Estalilla. We will discuss about pancreatitis. But first, let us have a quick recall of the structure and the function of the pancreas, an integral part of the digestive system. Pancreas is an organ located in the abdomen. It plays an essential role in converting the food we eat into fuel for the body cells. The pancreas has two main functions: an exocrine function that helps in digestion. It makes digestive enzymes and fluids in which they are released in the duodenum to help break down proteins, carbohydrates, and fats. Another function is endocrine function that regulates blood sugar. The disease of the pancreas, called pancreatitis, is an inflammation of the pancreas that occurs when pancreatic enzyme secretions build up and begin to digest the organ itself. It can occur as an acute, a painful attack lasting a matter of days, or it may be a chronic condition that progresses over a period of years. Acute pancreatitis refers to the pancreatitis that develops suddenly, most often as a result of gallstones or alcohol ingestion. Reaction to certain medications, trauma, and infectious causes can also lead to acute pancreatitis. Acute pancreatitis can be life-threatening, but most patients recover completely. Moreover, this acute pancreatitis occurs more frequent in middle-aged life and more common in women than men. On the other hand, chronic pancreatitis refers to the ongoing disease in which pancreas continue to sustain damage and lose function over time. The majority of cases of chronic pancreatitis result from ongoing alcohol abuse, but some cases are hereditary or due to disease such as cystic fibrosis. Alcohol abuse and malnutrition are also common of the chronic pancreatitis. Manifestations are same with acute except of the chronicity and recurrence. Now, the possible causes of the pancreatitis. Mechanism causing pancreatitis are usually unknown, but it is more commonly associated with autodigestion of the pancreas. So first we have the alcohol abuse. 80% of the patients with pancreatitis have biliary tract disease or history of long-term alcohol abuse. Alcohol is commonly associated with acute pancreatitis in the developed countries. Acute pancreatitis typically occurs after a binge of heavy drinking. Chronic heavy alcohol ingestion may lead to chronic pancreatitis and may increase susceptibility to episodes of acute pancreatitis. A number of mechanisms are responsible for alcohol-induced damage to the pancreas. Alcohol, or its metabolite, acetaldehyde, can have a direct toxic effect on pancreatic acinar cells, leading to intracellular trypsin activation by lysosomal enzymes. Additionally, inflammation of the sphincter of Oddi may lead to retention of hydrolytic enzymes in the pancreatic duct and acini. Alcohol also appears to increase the precipitation of pancreatic secretion to form protein plugs in the small ductules. Malnutrition may dispose patients with alcoholism to pancreatic injury. Other possible cause is these bacterial or viral infections. Pancreatitis occasionally develops as a complication of mumps and virus. Duodenitis. Spasm and edema of the ampulla of Vater can probably cause pancreatitis. Then we have the medications. The use of corticosteroids, thiazide diuretics, oral contraceptives, and other medications have been associated with increased incidence of pancreatitis. Moving on to the pathophysiology of the pancreatitis. So as mentioned earlier, we have the possible causes. the precipitating factors, the alcohol abuse, bacterial or viral infections, duodenitis, and medications. This leads to damage to pancreatic cells, causes inflammation. This results to edema of the pancreas and pancreatic duct. Now, obstruction to the flow of pancreatic enzymes such as the amylase, lipase, and trypsins occurs. This causes activation of the pancreatic enzymes inside the pancreas. The most common damaging among the pancreatic enzyme is trypsin. It eats up and erodes pancreatic tissues. Then the autodigestion of the pancreas, in which the digestion of the pancreatic tissues by the pancreatic enzymes leads to fatty necrosis, ulceration, hemorrhage, and infection. The clinical manifestation of this pancreatitis are the following. Pain. It normally begins in the mid-epigastrium or left upper quadrant with radiation to the back. Pain may be intensified by a fatty meal, alcohol, or lying in a recumbent position. Next is nausea and vomiting. Because pain stimulates the vomiting center and causes gastric and intestinal hypomotility. Abdominal tenderness and distension with fever due to paralytic ileus that follows peritonitis. Anorexia and weight loss. These are due to inadequate metabolism of nutrients. Next is severe dehydration. Excessive or loss of fluid results from fever, nausea and vomiting, loss of blood and plasma proteins into the retroperitoneal space. Hypovolemia may lead to shock. Then hypocalcemia. Calcium is deposited in areas of fatty necrosis and undigested intestinal fat traps calcium in feces. Calcium is lost in the steatorrhea. Next is jaundice, caused by common bile duct obstruction by pancreatic edema and seen in clients with gallstones-associated pancreatitis. Hemorrhagic pancreatitis produces post-hemorrhagic necrosis. This causes purplish discoloration. We also have the Cray-Turner signs and the Collins signs.
Let's now head on to the possible nursing diagnosis of pancreatitis. So I have three examples here. We have acute pain related to edema, distension of the pancreas and peritoneal irritation. I also have imbalanced nutrition, less than body requirements related to inadequate dietary intake, impaired pancreatic secretion, and increased nutritional needs. Ineffective breathing pattern related to splinting from severe pain, pulmonary infiltrates, pleural effusion, and atelectasis. Then here we have our nursing interventions or management. So have to relieve the pain using our drug of choice. Mipridine is the drug of choice. Morphine is contraindicated because it may cause spasm of the sphincter Oddi, which may potentiate ongoing pancreatic parenchymal injury. Pain relief may also be obtained by sitting in bed with the knees flexed and pressing a pillow over the abdomen. The client generally experiences more pain when in supine position. Next is the diet. Nothing per RM status is maintained during acute phase. Ingestion of food increases pancreatic secretion, which may increase inflammation and pain. As pain subsides, clear liquids are given, then gradual advancement to bland, low-fat diet as prescribed. TPN may be necessary for severe nutritional depletion. Intravenous fluid therapy is used to maintain fluid electrolyte balance. We also have nasogastric tube insertion as prescribed to remove gastrin from the stomach and secretin from the duodenum. This reduces the stimulation of the pancreas. Digestive enzymes, pancreatin, pancrelipase, as prescribed. This medication should be taken with each meal and snack. Food helps to buffer the stomach acid. A high fiber diet may be enhanced may enhance efficacy of the medication. Then absence of Sclerotia indicates the effectiveness of medications. Next is administer fat-soluble vitamins, vitamins A, D, E, K as prescribed. Fat-soluble vitamins are lost in during steroiduria. Next is to administer antacids to neutralize gastric secretion. And we also have to administer histamine receptor antagonist as prescribed. This is to decrease HCl production and prevent activation of the pancreatic enzymes. And administer anticholinergic as prescribed to decrease vagal stimulation, decrease gastrointestinal motility, and inhibit pancreatic enzyme secretion. Next is to administer antibiotics as prescribed to treat infection of the pancreas. You also have to administer calcium supplement and vitamin D as prescribed to manage hypocalcemia and to for vitamin D to enhance absorption of calcium. Next is to instruct client on the importance of avoiding alcohol. Then we also have to instruct the client on the importance of follow-up visits with the physician. Instruct client to notify the physician if acute abdominal pain, jaundice, clay-colored stools, or dark urine develops. These signs and symptoms may indicate occurrence of complications such as pancreatic abscess, colonic or bile obstruction, or metabolic and renal disorders. We also have surgical management for pancreatitis. We have here the side-to-side pancreaticojejunostomy, the ductal drainage. This is indicated when dilation of pancreatic ducts is associated with septa and calculi. This is the most successful procedure with success rates ranging from 60% to 90%. The Ductal pancreaticojejunostomy, ductal drainage is indicated for uncommon causes of proximal pancreatic ductal stenosis, not involving the ampulla. Pancreaticoduodenal, the right-sided resection ablative with preservation of the pylorus, the Whipple procedure, is indicated when major changes are confined to the head of the pancreas. Preservation of the pylorus avoids usual sequelae of gastric resection. Then we also have pancreatic surgery. A patient who undergoes pancreatic surgery may have multiple drains in place post-operatively, as well as surgical insertion that is left open for irrigation and repacking every 2 to 3 days to remove necrotic debris. The prognosis of pancreatitis. So most of the people with a mild case of acute pancreatitis fully recover. However, with those severe pancreatitis are more likely to have life-threatening complications. Then speaking of complications, we have here 6 possible complications of pancreatitis. So we have here shock. Shock may occur in severe acute pancreatitis as a result of several interrelated factors. Hypovolemia. Hypovolemia results from a massive exudation of plasma and hemorrhage into the retroperitoneal space and from fluid accumulation in the gut. As a result of ileus, hypotension and shock may also result from the release of kinins into the general circulation. Next is the DIC, or the disseminated intravascular coagulation. Tissue factor and Tissue factor release and expression during proteolysis may activate the plasma coagulation cascade and may lead to DIC. We also have pulmonary complications. The severity of pulmonary complication can vary from mild hypoxia to respiratory failure or ARDS. It is estimated that 50% of early deaths in patients with severe acute pancreatitis are associated with respiratory failure, owing to profound acute lung injury. The pathophysiology of this acute lung injury appears to involve an increase in permeability of the alveolar capillary membrane. The endothelial cell destruction in the alveolar capillaries may be mediated by circulating activated pancreatic enzymes, including elastase and phospholipase A2. Pulmonary surfactant, another important alveolar barrier, appears to be destroyed by phospholipase A2. Next, we have pancreatic pseudocysts, are non-epithelium lined cavities that contain plasma, blood, pus, and pancreatic juice. They are a product of inflammatory fibrous or granulation tissue walling of the peripancreatic fluid collection. By definition, pseudocysts are distinguished from acute peripancreatic fluids collections by their persistence more than 4 weeks following an episode of pancreatitis. Pseudocysts usually occur after recovery from the acute attack and are the result of both parenchymal destruction and ductal obstruction or disruption. Some acini continue to secrete pancreatic juice, but because the juice cannot drain normally, it collects in the area of the necrotic tissue, forming ill-defined pseudocysts. As more juice is secreted, the cyst may grow larger and may compress nearby structures, such as the portal vein, common bile duct, or the gut. Pancreatic pseudocysts are distinguished by their lack of solid debris appearing as homogeneous fluid-filled cavities on imaging studies. Next is the pancreatitis. This occurs when a direct connection develops between the pancreatic duct and the peritoneal cavity given its origin. It is unsurprising that the acidic fluid resembles pancreatic juice. Characteristically, an exudate with high protein and extremely high amylase levels left untreated massive pancreatic ascites may lead to pleural effusion, subcutaneous fat necrosis, or abdominal compartment syndrome. Treatment typically involves draining the ascites and controlling the pancreatic ductal disruption either by endoscopic pancreatic duct stent placement or by surgical therapy. Lastly, we have pancreatic fistulas. It's caused by the disruption of pancreatic duct. This should be suspected in patients who develop pancreatic ascites or pleural effusion. Fistulas can be internal, connecting to pleural or pericardial spaces, the colon, the small intestine, or the biliary tract, or external, draining through the skin. That would be all for pancreatitis. Thank you for watching.